Hey everyone, I'm Mike Moore, and I'm a second-year emergency resident at West Virginia University. I'm presenting a case entitled Point of Care Ultrasound as the Key to Rapid Diagnosis in a Unique Presentation of Dyspnea, originally authored by Brian Dilcher, Erica Shaver, Joe Minardi, and myself. This was a very rewarding case with some great ultrasound images, and we hope that you find it interesting as well. Dyspnea is an extremely common complaint in the emergency department. In 2016, this accounted for 3.4 million emergency department visits in the United States alone. The differential diagnosis is extremely broad, and point-of-care ultrasound is a rapidly available imaging modality that can be used to help narrow the differential quickly. In our case, you will see that point-of-care ultrasound was the key to the rapid diagnosis. Our case begins with a 48-year-old male who presents to the emergency department with cough and worsening dyspnea on exertion for the past 11 months. He had been previously evaluated by his primary care provider, ENT, urgent care, and pulmonology, and had been treated for sinusitis, bronchitis, seasonal allergies, and GERD. He had a negative CT pulmonary angiogram the day prior as an outpatient after he had lab work showing an elevated D-dimer and troponin. The patient had no significant past medical history or past surgical history, and no known drug allergies. He was currently taking cetirizine, Atrovent, Singulair, pantoprazole, prednisone, and testosterone supplements. He drank 3 to 7 alcoholic drinks per day, did not smoke cigarettes, denied any other drug use, and was employed as a commercial airline pilot. His family history was negative for venous thromboembolism, early cardiac disease, pulmonary disease, or aortic disease. The patient's initial vital signs were significant for pulse ox of 88% on room air, heart rate of 108, and blood pressure 138/90. Notable findings on physical exam were that the patient was in moderate respiratory distress with conversational dyspnea. He had crackles in his bilateral lung bases and no pedal edema. Within 5 minutes of his arrival, his EKG and bedside echo were performed. His EKG showed sinus tachycardia with some nonspecific changes only. Here are 2 still shots from the parasternal long axis view from our actual patient. Frame A is unlabeled and frame B is labeled for reference. As you can see, there is a rounded mass, which is labeled thrombus, sitting in the apex of the left ventricle. This is the actual clip of the parasternal long axis view on our patient, and we immediately notice the rounded mass that is seen in the apex of the left ventricle. However, we also noticed that there was an overall poor LV ejection fraction. Here are 2 still shots from the apical 4-chamber view from our actual patient. Once again, frame A is unlabeled and frame B is labeled for reference. And again, you can see that there is a rounded mass labeled thrombus in the apex of the left ventricle. This is the actual clip of the apical 4-chamber view on our patient. Here we were able to even better visualize this mobile, rounded mass seen in the apex of the left ventricle. And just as in the parasternal long view, we note very poor LV ejection fraction. Overall, the ultrasound showed us a dilated, globally hypokinetic LV with significantly reduced ejection fraction, a large mobile LV thrombus, and B lines present in all lung fields. This led us to a diagnosis of decompensated heart failure secondary to dilated cardiomyopathy with associated LV thrombus. The patient was immediately started on supplemental oxygen, which he responded to quickly. A heparin drip was initiated, cardiology was consulted, and the patient was given IV Lasix and metoprolol. He was admitted to the heart failure service. The cause of his dilated cardiomyopathy was undetermined, but suspected to be multifactorial due to his alcohol use, testosterone use, LV non-compaction, which was seen on his cardiac MRI, and obstructive sleep apnea. He was discharged several days later with optimal medical therapy, warfarin, and a life vest. He was advised to stop drinking alcohol and taking testosterone supplements. He was also advised to undergo a sleep study. His 30-day follow-up TTE showed that the LV thrombus had resolved, but he had no improvement of his EF at that time. In conclusion, in this scenario, bedside echocardiography allowed for rapid diagnosis of a previously overlooked etiology of this patient's dyspnea, and the quick development of a treatment plan. Previous studies have demonstrated that point-of-care ultrasound performed by EM residents is comparable to echocardiography performed by a cardiologist, and we would assert that bedside echocardiography should be a routine part of the ED evaluation of dyspnea. These are our references. As I said during the introduction, we found this case very exciting, gratifying, and real time, and I think our patient ultimately benefited from receiving a rapid and accurate diagnosis, which is ultimately what this is all about. I want to thank my co-authors again, Dr. Brian Dilcher, Dr. Erica Shaver, and Dr. Joe Minardi. Thank you for your time.